prominent medical group in Mumbai, continually enhancing her expertise in dermatology. Dr. Bhagyashree, please join us on stage. You have 30 minutes for your presentation. Over to you.
Hi, I am Dr. Bhagyashree Gupte, and I'll be talking about post-procedure skin care. Though the lecture before this was very exciting, in my lecture I'm going back to pathology. So if you guys want some tea or anything, please help yourself. So a healthy skin. How do we characterize one healthy skin? So this is what we actually look forward to, like all our clients or our patients come to us with the hope of healthy skin. So if we want to categorize a healthy skin, how can we divide it for our references? So firstly, it should be a well hydrated skin. Secondly, it should be an even toned skin. And thirdly, with some smooth texture. Now, the clients or the patients who come to us, they either have a slightly damaged skin or they have a good skin. And still they hope us to get better. Okay? So if we are given with a good skin and we are hoping to make it better, how do we do it? Of course, the creams are there, the home care is there, but a major factor is the procedures which we do in the clinic. So when we come across a good skin in an attempt to make it better, we make it undergo a lot of procedures. These procedures are maybe micro injuries or micro trauma in an attempt to rejuvenate or regenerate the skin better. So when we are giving that kind of micro trauma, we have to make sure that the skin is in a sound state so that it can take that trauma, utilize it for the growth, and then enhance the result. So here I would be talking most importantly about the pre-treatment, during the treatment and the post-treatment, where there would be a downtime, where there would be little hand-holding which is required from our side so that we give that enhanced results. So what are the type of injuries which we, passively or actively give our patients? Firstly, they can come to us with these burns or wounds, or there can be other widespread injuries like electrocoagulation or dermabrasion or microneedling or even laser CO2. There can be linear injuries like surgical procedures or actinic keratosis, wart removal, C-section or scars. Now, while in an attempt to give a good injury, what are the possibilities where we can slightly go wrong? So the post-procedure not so great outcome can be, of course, bruises, it can be PIH, it can be burns, it can be infection, but the most dreaded one can be scars. If you've called someone and, few things which my seniors have told me is two things you cannot do wrong with the patient is if they've come for an aesthetic procedure, first should be you cannot worsen the outcome. And second should be, you have to make sure that you do not give them a lot of pain, because this is an elective procedure. Finally, they are deciding it by choice. So you cannot give them pain where, especially the derma rollers or microneedling, you cannot make them go through a lot of pain just to give that procedure results. So here I was talking about the post-inflammatory hyperpigmentation, burns, infection, but the most dreaded one would be the scars. And why we are emphasizing more on scars, because the patient's perspective of living with a scar, what the studies have found out that 12 to 23% experience depression, around 13 to 45% have a traumatic stress disorder. One study looked at the quality of life after scarring in adult patients with variety of scars. They were unhappy, of course, with the scar's appearance because of the stigma and the psychological association. They also adopted a different type of coping behavior to hide or compensate, which made them antisocial and interfered with their communication skills and personal relationship. So the scars have a big impact. Also, the survey said the patients are equally concerned about the scars both on the visible as well as the non-visible parts of the body. And here they got a little grumpy on us, saying we are not as considerate as them when it comes to scarring. That means they were expecting us to have more better communication. They were expecting us to be more empathetic in the outcome. Here I make sure that if I have in my practice, if I have something like, even DPNs or freckles, where I know the tendency of the patient is to leave pigmentation, especially that when, because there is some insulin resistance, that any kind of injury is going to throw back pigmentation, there please put your foot down and say this is not the right time. It is very essential for us to say no, so that we make sure that the percentage of patients getting happier with our results stay high. If just for the sake that I found it, this is the treatment and I want to get it done, that won't be the right thing to do for every patient. So yes, you have to make them aware of the possibility of scarring before going through the treatment. And the good part, in spite of being grumpy, they have given us a small hope that they agree that a small improvement in the scarring also is worthwhile. So it's worth the extra one effort which we take, because that makes a lot of difference. Now, to get on to how it can lead to scarring, we have to know what is the procedure of normal wound healing. So wound healing, back to our pathology classes, the process of wound healing begins at the moment of the injury and may continue for years. No matter how trivial or extensive the wound is, healing includes 3 overlapping phases, that is inflammation, proliferation, and differentiation. So these are the phases: inflammation, granulation, tissue formation, wound contraction, and then collagen remodeling. Now here I want to emphasize a little bit increase in the inflammation can have a lot of chemokines and cytokines, and that can backfire as our post-inflammatory hyperpigmentation or also a little bit of scarring. So there you have to be very careful in the very initial stages of wound healing. Normal wound healing and scar formation. So the skin wound healing is an innate immune response of the tissue injury that finishes with the wound closure and restores the skin barrier function to prevent infection. It is a complex process, as I said: inflammation, proliferation, and remodeling. Now, the prolonged wound healing or excessive host response to the injury prevents the normal process, and it can lead to anesthetic scarring. Factors which are affecting wound healing is, of course, the age, ethnic group. So if 65, 69-year-old female comes to you with a lot of skin tags, think twice. Also think how much is it essential aesthetically for her. It shouldn't happen that you go to give her a very pretty face, but there are these infections or prolonged wound where the body is not healing. So again, choose the patient very wisely before starting with any of the procedures, however small it is. Then, of course, extrinsic factors like smoking, sun exposure, physical activity, comorbid conditions, psychological stress, poor nutrition. Yes, here we quite neglect the stress part and the nutrition part. You also have to ask, if you're going for an elective procedure, you have to ask the patient that how easily their injury heals. If they tell you कि no, they keep leaving marks, oh ये मुझे लगा था wax से 4 महीने पहले and it's still darker, or it has given a white mark, please do not start. At least start with some nutritional tablets for them. Make sure that the wound is healed, and then you start with the procedure. Again, smoking is also, and here while for wound healing, one important factor is also that you have to check that if they are on antioxidants, make sure that you stop them at least 4 to 5 days prior to the procedure, whether it's normal green tea or the vitamin C, but they have to, otherwise you will end up using excess of gauze trying to stop their bleeding. And wound location and associated mechanophysiological conditions are also responsible. These intrinsic and extrinsic factors affect the different phases as discussed. Now, ethnic groups, why ethnic groups are very essential? Because the keloidal tendency runs in the family. Luckily, Indians are not that prone to keloidal tendency, but it's always better to ask them, okay, these people might not know that they have keloid, so ask them whether on their sternum or on their arms, whether they have this extra growth which just came, or maybe, कुछ normal लगा था, or the marks of their vaccination. If they are excessively huge, then think of the keloidal tendency. Also ask how their parents, any of their parents have any of these. Age, as I said, is very essential, delayed in even healthy but older individuals. Increasing age is associated with morphological and structural changes, altering the inflammatory responses, and the skin function deteriorates, and each stage of the healing is affected. Now, the extrinsic factors would be, yes, the glucocorticoids. So the medications, as I said, very, very, very important to ask the drug history. So first is glucocorticoids, which are responsible. They are going to reduce your inflammatory response and, of course, increase the risk of infection. Apart from that, the antioxidants. Thirdly, the blood thinners are also responsible. You have to know you are taking them for an elective procedure. So if they are on aspirin or clopidogrel, we don't have the right to stop it just for an elective procedure. You have to be mentally be prepared that they are going to bleed a little higher. You have to already align them for the same, but do not stop their medicines. Yes, glutathione, vitamin C, and all these other antioxidants which are secondary can be stopped at least 4 days prior to the treatment and minimum 2 to 3 days after the treatment. Also, if they do not have bruising, they can start with it, but if you are expecting some healing, then you can slightly delay it as well. And comorbid conditions, diabetes and peripheral arterial diseases, very important. The chances of infection increases. Also, the healing tendency changes because of diabetes. Smoking is a well-known factor. Stress in delayed wound healing. In my practice, I have seen if people are stressed, more or less, they do throw a lot of post-inflammatory hyperpigmentation. A few very obvious sites are around the mouth or the darkening of their dark circles, but please make sure you check them. Also, you can check their knuckles and their elbows to see whether they have a little higher pigmentation as compared to rest of their body. Underarms can also be noted. You can just have a history of it. Exposure to UV radiation can, of course, increase the scar pigmentation, worsen the clinical appearance. Here, post-inflammatory hyperpigmentation can also happen once the skin is completely healed. You've gotten a regular normal skin, but after, say, 7 to 10 days also, the site of injury can throw pigmentation. So it is very essential for you to inform them that if they are going for an elective procedure, especially chemical peels or microdermabrasion or microneedling or CO2, that even if the skin gets back to normal, it is going to be slightly sensitive as compared to your normal skin. So you cannot have a trek planned or a pool party planned even after 15 days of your procedure. Factors affecting wound healing, the wound location. Wound location and associated mechanophysiological conditions particularly influence the degree of scars. Mechanical stress, including skin stretching, stimulates the mechanosensitive nociceptors and sensory fibers. Those with greater edge tension, such as deltoid and sternal regions, are at a higher risk of severe scarring and keloidal development. So what is an optimal microenvironment which we can provide? So an ideal microenvironment for the wound healing, if it's an elective procedure, then of course you have to make sure this is happening before the start of the procedure. If you come across any injury, then make sure that post that you maintain this. Which the ideal condition should be clear of debris and infection, and optimal moisturizer content is maintained. Here I want to really emphasize just a normal regular moisturizer can make a lot of difference in basic procedures, whatever procedures you do, whether they are your microdermabrasion or peels or anything. Just adding a nice non-fragrance moisturizer would make a lot of difference. Moisture creates a water barrier by occluding and hydrating the stratum corneum and epidermis. After an injury, an evaporative water loss from the wound surface can be up to 4 times greater than that of the normal skin, and once healed may take at least up to a year to regain the pre-wound level. So spontaneous healed scars have known to have a higher transepidermal water loss than scars from a skin graft. The hypertrophic scars have a higher TEWL than normal scarring, and keloidal scars, which extend beyond the border of the injury, have even higher TEWL rate, thus supporting the cutaneous hydration as the most important optimal part of the healing. The role of basic skincare to optimize healing. Basic skincare may provide a barrier and maintain a moist microenvironment required for optimal healing. Seems to have key role in the remodeling phase of wound repair. Silicone sheets and gels are considered, of course, as the gold standard for preventing excessive scarring. Hydrating creams could be an alternative to silicone gels in scar prevention. The current scar management guidelines highlights the importance of hydrating cream and silicone products to provide occlusion and hydration to provide an optimal healing environment. Emollients and humectants such as urea, AHAs, and hyaluronic acid retain moisture in stratum corneum. This helps to maintain the skin hydration to preserve the skin barrier function, which reduces the itching and discomfort associated with the scars and enhanced wound healing. Now, the role of optimizing the healing, of course, solar radiations, we want it to be avoided. So the current international guidelines have suggested a strict photo protection with a maximum SPF of 50 until the scar has matured. Now, the thermal spring water here has a very unique characteristic and a very important factor, or it can be like a key ingredient which can show an anti-inflammatory and immunomodulatory effects, which induces accelerated skin healing and reduces the itching in the scar formation and dermatosis. Then, of course, corrective makeups are very essential to keep the psyche of the patient in a better state, especially if there are scarring, melasma, or vitiligo. Now, an overview of the supportive skincare recommendation for pre, peri, and post-procedure. Now, for non-surgical procedures involving large surface area, most importantly, the pre-procedure should include applying a lot of broad spectrum sunscreen for at least 1 month prior to the procedure. The skin must not be tanned at the time of the treatment, especially if you're doing some vascular laser procedures, tattoo removal, or laser pigmentation, or even laser hair removal. Here I want to emphasize, if the darker the skin and black is the melanin, laser hair reduction, the technology is blind. It is just works on the color. So it would not understand whether it's your skin pigmentation or your hair pigmentation, and the skin is going to absorb more energy as compared to your hair, giving superficial burns. So make sure that you take the history of their trips just prior to starting with any of these procedures. For ablative fractional resurfacing techniques, antiviral treatments can be started, especially if they have the history of recurrent herpes. So make sure that you don't want to be responsible for another attack. So it's better to put them on a prophylactic treatment. For laser hair removal, medium depth peel, mesotherapy, PRPs, percutaneous collagen induction, microneedling, thread lift, hyaluronic acid fillers, or start with the anti-herpetic treatment, especially a week prior with recurrent herpes infection. If without a history, you don't need to start it. Peri procedure would include a high tolerance cleansing milk or micellar solution to remove the makeup. Avoid alcohol solution. Mist with thermal water or ice packs to cool and soothe the skin. Consider applying a repair cream with anti-redness or soothing ingredients immediately after the procedure. Post-procedure, yes, healing and calming or moisturizing balm adapted for the treatment type. applying a broad spectrum sunscreen daily, minimum 15 minutes prior to the sun exposure, reapplying it every 2 to 3 hourly, and physical barrier is like the best protection. Avoiding direct sun with wide-brimmed hats, and sunscreen needs to be applied on the scabs as well. This part we generally forget, so this is very important. Also, apply high tolerance perfume free corrective makeup if necessary. What is most important is the patient should be in a good sane state. So if tinted sunscreen helps, then so be it. If camouflaging helps, so be it. The moment this is relieved, the stress is relieved, the skin is going to give much better response. Remove the makeup with a high tolerance cleansing milk. Again, make sure if you're applying the makeup, you have to cleanse it back once you're back. Use of adjuvant skin procedures, skin care adapted to cosmetic objectives. For surgical procedures combined with surgery of skin grafting, again, similar disinfection is most important. And while doing the procedure, make sure asepsis is maintained. Clean the wound, close wound with a cleansing solution, and appropriate dressing is important. And post-procedure, applying silicone sheets, very important. Massage the wound with repairing balm. Also massage a little surrounding area for lymphatic drainage. Applying a broad spectrum sunscreen and corrective makeup. And again, wash the wound with thermal spring water. It is very, very, very useful. Localized non-surgical procedures like superficial peeling or injections or threads, same SPF cleansing, and make sure that they are not on any of the night creams. Most of the night creams can be irritants, so make sure that at least 4 days prior to your treatment, you stop their retinols, you stop their niacinamide. Make sure they only, for 4 days prior, just a moisturizer and sunscreen would work the best. Pre-procedure, peri-procedure, it would be cleansing milk. Again, more or less the similar thing. Thermal water can be considered, and post-procedure, calming and healing creams. Now, the supportive measure for managing scar in case of optimal outcome, in case you are sure that there is a chance of scar formation. Then the wound healing, for cleansing, thermal spring water or a disinfectant wash. Here I would give a little edge to the thermal spring water as compared to disinfectant, because a lot of times when they clean with the disinfectant, they take away also the granulation tissue, which is important for regeneration. So somewhere they only delay in an attempt to cleanse it too vigorously, they take away the granulation tissue, thereby healing process gets prolonged. So the thermal spring water, yes, it has an anti-inflammatory, immunomodulatory, and anti-itch property. Gentle cleansers, it reduces the infection and prevent crust formation, and disinfectant wash prevents infection. Now for healing, we'll go for silicone sheets and gels. They are of course occlusive healing, maintain skin hydration, and emollients with advanced hydrating properties like hyaluronic acid formulation adapted for massage for better skin hydration. Photoprotection and camouflaging. Photoprotection again to avoid PIH, SPF minimum of 50, and corrective makeup as well. General recommendation for optimal scar management, clinicians should consider optimal scar management for any patient considering the following intervention. Patients at the risk of delayed healing, hypertrophic or keloidal scar tendency should consider a post-intervention wound care plan. The management choices should be tailored to the individual requirement, and the patient should be encouraged to take an active role in the management of their scar. Early consultation is required. Now, general management for optical scar management, of course, basic skin care, very, very, very essential. Scars should be re-evaluated every 4 to 6 weeks after the surgery, determining whether it's hypertrophic scar or atrophic. And medical management is required. Scars continue remodeling 6 to 12 weeks post-surgery, so occlusive therapy and photoprotection is essential. So here what is very important is going to be patient education. So Patients may lack confidence in managing their wound, and health professionals can provide support in their self-management. Hand-holding is very, very, very essential. However, troublesome it can get to us, but that's when it is going to heal after maybe 6 weeks, 12 weeks, but whatever care you gave in that patient is going to remember lifelong. So make sure that you do hand-holding properly. Advice to the patient would be start the treatment as soon as the wound occurs. Always keep the area clean with washing hands, and then the area to help avoid infection. Dry with a clean towel, try to pat dry it or use gauze, or make sure that it is at least distilled. Do not rub it dry. Use a petroleum jelly or similar ointment to keep the wound moist and to prevent scab that can delay healing. Adhesive bandages like Band-Aid, gauze, silicone gels can be used. Change the dressing every day to keep the area clean. Follow advice to wound care specialists for wound requiring stitches. Avoid scratching or picking the scars that can make it more likely to scar. Minimize movement and overexerting the area. Massaging the area regularly may be helpful. Avoid exposing the wound too much to the sun. And any scar which is still bothering the patient, skin camouflaging or makeup specifically designed to cover the scars can also help. It can take time for some scars to fade, so remember, we need to advise the patient to be patient. So coming to the summary, majority of the patients concerned about scarring result from elective or aesthetic procedures irrespective of their sex or geographical region. There can be a discrepancy between patients' concern about scarring and their readiness to discuss scarring outcomes with their surgeon. To address this discrepancy, surgeons need to be very clear, maybe if possible show them some pictures and communicate the possibility and severity of the scarring following the surgery, demonstrate that they are doing all that is possible to reduce the scarring, irrespective of how small the final scar might be. As experts in the management of scarring, we would have to develop guidelines that can facilitate post-operative management of scars. Thank you so much. Do you have any questions related? Yes.
Hi, so you talked about dealing with patients who have keloidal tendencies. So if there is a patient who has very extensive atrophic acne scars, who is aware of the keloidal tendency and still insists on improving the appearance, so how do you personally counsel the patient, accordingly?
So honestly, it is a double-edged sword. Okay, but I have a couple of patients. I won't give you an advice what is ideally right, but I'll tell you what I follow. So they do insist whether it's hair laser reduction or acne scars they want. We also have to know that because they have gotten a keloidal tendency, there is a problem with their collagen. So they are going to throw scars, like whether it's their face or anywhere on the body. When it comes to acne scars, try to put them on oral retinoids and a topical retinoid to make sure how much we are, improvement we can get. If they are happy with it, you are lucky. If they're still not happy, you can consider a milder microneedling radiofrequency technology. That is what I do. Ideally, going with the books, we should be avoiding these things. But if they do not have a scar, keloid on the face, that's when you can consider a low frequency MNRF. If it's on their jaw, please do not touch them, come what may. But otherwise, I avoid derma pen, I avoid derma rollers, because there, the pressure matters. So you are not giving them a controlled injury. If you go with the microneedling, the injury can be controlled. You know what intensity you are using. You know what the RF is. You know the depth is. Without much of a mechanical pressure, you can give it an attempt. There you can also please counsel the patient. Whenever I have done a MNRF, I have made sure I write, make sure that I take it from writing from them that they are aware and still they want to go ahead with the technology. So make sure that you get your papers right. And pre-procedure, yes, retinoids can be added, so that should help. And make sure that, while post-procedure also, you use good healing creams, and there shouldn't be any other trauma if you are already giving a trauma. So hydration has to be at place, no excessive sun exposure. All these factors are also very important when you are doing such tricky things on the patient.
Okay. And just the last question. In these patients who have, suppose they have a keloid on the face, do you do a test spot with first, or do you just proceed with the
I
treatment
do
altogether?
not touch them, no.
Okay.
Because when it comes to keloid, they have specific locations, right? So if that keloid is there only on specific location and the face is clear, then you still can justify that the face is not involved. But if, especially on the jawline, if they have keloidal tendency, please do not do any procedures. No.
Thank you.
In what removal procedure do we required any medical test before?
It depends upon how severe, what is the severity of the warts. If you come across a patient who has one wart, you don't need to do any, at least I do not do it, any investigations before. You don't have to take too much of medical history as well. It's just, fulgrate it and you're done. But if you come across a patient who has multiple warts, like, maybe more than 20 all over the body or on the face, then make sure you get their immunity test done. Like, I get their blood sugar levels and tridot tested first, and then you start with it. Again, very important to know whether if they have any other medications going on, like steroids or blood thinners. So these are the only two investigations I do, that's it.
Okay, and for the diabetic patients?
So for diabetic patients, you have to be careful. What you can do is start with an antibiotic. Again, see what becomes a viral infection. So if it would have been some DPN or anything, just ask them to avoid, as long as if it's aesthetically bothering them. What becomes a viral infection, we need to fulgrate it. What you can do is, you do not go way deeper giving an open injury. So make sure that you fulgrate, explain to the patient that you might require another sitting as well. If again 1 or 2 warts fulgrated, get it done. But if there are multiple, put them on an antibiotic before starting with the procedure, at least 2 to 3 days prior, and then you do it. And then make sure that it is not haywire, like the blood sugars should be under control, and they should be on oral hypoglycemics. Without that, please don't touch diabetic patients.
Okay, thank you, ma'am. Thank you so much.
Hi, ma'am. If someone is prone towards the keloid, is it safe to do microneedling?
So as we were discussing the same thing, ideally no, but you would come across patients who want results. Okay, so as I said, that location of keloid is very, very, very important. If you are doing some part where there is no keloid, not even active, even if it's a dried keloid, still you are not going to touch it. But if there is no keloid on the face, you can give it an attempt. With intensity and severity has to be controlled, and make sure that you get it in writing. You should not be the one who should propose that microneedling to them. So if they come to you asking for it, you have to educate them that there is a possibility that it can backfire. Make sure you get it in writing from them. Do a test spot, patch test, and then you start.
Okay, one more, ma'am.
Yes.
A post-care of glutathione, after glutathione, what we can
Are you talking about oral or IV?
IV?
So post-care IV, see, IV gluta doesn't need any as such post-care. Okay, because it's a normal IV, as as normally what the normal saline or DNS is given.
Yes.
So specific to gluta, there is not going to be any specific post-care things. But as such, what we give for IVs, make sure that there's not you do not load too much of dose together. So these all factors become the pre-one, and give a test dose prior to giving. So all these factors would be pre, nothing post.
Thank you.
Okay, we'll be taking a last question now, and then we'll move on to the next question. So next session, so last question.
And there was a case of chickenpox 10 years back, and the patient underwent a surgery for that. And the patient started having keloid at the same position. It was around 7 stitches surgery for removing of that scar, atrophic scar. And the patient developed around 2 inches of keloid. Does the patient have tendency on other side also if the patient is having injury?
Yes,
she might have.
absolutely, absolutely. Because see, keloidal tendency runs completely in your entire body. It won't be specific. Now, here again, as to point out, what is important is how controlled you give the injury. If here we are talking about MNRF, which can be done on the face, but there you are doing a control micro injuries where there is a small crater and there is a regular normal skin available to make sure it grows. Okay, so we are not giving a complete prolonged good injury. But if it's a keloidal tendency, again, whether it's a hypertrophic scar or keloid is very important. If they have, sorry, see, keloid is if it is post surgery, it has to be a hypertrophic scar. Keloid, the definition of keloid is it should happen without any injury. That is what is keloid. So if that tendency becomes hypertrophic scar. So if that person has a hypertrophic scar tendency, we are not going to do the MNRF also. Here, keloid and hypertrophic scars are completely different. They look entirely same, but their history is the only thing that can differentiate between the keloid or hypertrophic scar. So if it's a hypertrophic scar tendency, they are going to develop it the next place as well. Again, here also what is important is whether they have that hypertrophic scar tendency or it is just because the surgery went too deeper. So these factors, the rule is going to be every patient would have different rules. So you have to take the history very carefully. There are cryo as well, but Kenacort stays my favorite as well. Then cryo is, no, but see, 25% patients are not going to respond to anything. So you have to be mentally prepared for that and accept that. And you have to tell them as well before starting with the treatment that, 25% patients are not going to respond to anything.
Okay, I'm very sorry for this, but we will have to end this session because we have a great lineup today and we need to move on next to next as speakers are also in. But Dr. Bhagyashree is going to be there here for a while and you all can take your questions offline with her. On the onset, I would like to thank Dr. Bhagyashree. The presentation was very informative, so thank you for the time, for joining us today for the presentation. Maybe you all want to thank her with a huge round of applause? Be more thankful, that would help. Thank you. And can I have you on the center of the stage, please? You all can continue thanking her. As I had mentioned at the start, this presentation was powered by Beatrice, and